Good afternoon, and thank you for joining us at our UnCommon course session, The Ethics of an Outbreak. I'm Dr. Robert Dargazi, a 77 graduate of the Pritzker School of Medicine. I'm past president of the Menn Biological Sciences Alumni Association. Now I'm on the Alumni Board of Governors. The ABG is a representative body of alumni whose aim it is to advocate for fellow alumni to ensure a rich and meaningful experience for all University of Chicago alumni. This afternoon, I have the pleasure of introducing our faculty presenter, Emily Landon, a hospital epidemiologist and assistant professor of medicine at the University of Chicago here, as well as medical director of the Antimicrobial Stewardship and Infection Disease Programs and a faculty member of the McLean Center for Clinical Medical Ethics. Dr. Landon received her MD degree from Loyola Stritch. She completed her residency and chief residency here at the University of Chicago, as well as a fellowship with the section of infectious disease and global health. Dr. Landon also heads the Ebola Preparedness team at the University of Chicago, which is one of only 35 national Ebola treatment centers. Today, she'll be talking with us about the recent unprecedented Ebola outbreak, other emerging epidemics, and the ethical questions and concerns that come with this work. Please join me in welcoming Dr. Landon for what should be a fascinating talk.
Wow, well, thanks for the great introduction, and welcome everyone today. This is my first time talking at one of these events. I'm very excited to be here and to share with all of you some of the really exciting things that happened at the University of Chicago last year in the fall and winter, and to talk a little bit about the deeper questions involved with some of the things that we need to do to prepare for taking care of patients that have incredibly infectious infections that may come to us from all over the globe. So let's just get started. One thing I did want to say is that this is an ethics talk, right? So we're going to talk a little bit about medicine and a little bit about what it means to make decisions about taking care of these patients. And one of the things that makes ethics conversations so important is having everyone participate. So there are plenty of opportunities in here for everyone to ask questions and to discuss, and everyone's opinion is important here. So raise your hand and be involved, and we'll have a much better discussion about this. So let's first start with a little bit of background information about Ebola. These are the parts of West Africa, just a reorientation to the globe. These are the parts of the world where we saw such an unprecedented outbreak of Ebola in the summer and fall of last year. And that makes up three main countries: Guinea, Liberia, and Sierra Leone. There were other cases in Nigeria, there were other cases in Mali, but we're not going to worry about them. There was no sustained transmission in those countries. The biggest risk factor for us living in the United States are the healthcare providers that go to these areas to work and the people from these areas that come home or come back to the United States or come to the United States because they're seeking care, like the patient in Texas, or for other reasons. So the first thing that we should start out by talking about is why this got so bad. There have been outbreaks of Ebola since 1967, when the first outbreak happened in what was then Zaire and is now the Democratic Republic of the Congo. And so the question is, why is this such a bad problem in Western Africa? And there are a lot of reasons why that is the case. First of all, Ebola migrated to Western Africa via bats because there was a loss of habitat in Central Africa, which allowed those fruit bats to move. And so this is a question of how we're handling our environment in Africa and across the globe. We are familiar with these themes. That pushed Ebola and its vectors into an area which had never seen Ebola before, a place that was pretty used to seeing other nasty infections like Lassa fever, which are less transmissible from patient to patient. And so they initially assumed that it was not Ebola. The next thing we have is that this is a very war-torn part of the world, a place where there is not very much infrastructure to manage healthcare, nor any money to pay for healthcare, or to even pay for basic things like clean water, clean food, and housing. And so we have a lot of urban overcrowding and poor living conditions that lead to people living close together, sharing environments they maybe shouldn't share, and not having safe, clean drinking water. The The next thing on the list is the traditional burial practices in this part of the world, which are also true of Central Africa, but became a problem in that urban area. So in these cultures, many of the traditions around the time of death involve ritual washing of the body by the attendees at the funeral, and then it is thought to be very unsavory and disrespectful if one cleans their hands before they proceed to the funeral lunch, where it is often prepared by the people who are attending the funeral as a way of giving back to the family and supporting the family. Everyone can see how this is a big problem for infection. And so you can, but it's also something that's very firmly entrenched in their culture, and so something that's very difficult to fix, even in the face of a very difficult and dangerous illness. Then we have the lack of health infrastructure. So there's no place for people to go when they are sick. There's no way for them to pay for care, and there's no way to provide them care because we don't have clean IV fluids, units that are available to isolate these patients, doctors that are familiar with this sort of illness, creating a problem where people keep their family members at home, which then encourages more spreading within inside the home. Foreign relief workers finally arrive on the scene in the late summer, early fall, when we start to understand that there's a bigger problem than we initially thought. And they show up in hazmat suits with these like things, you know, like the guy that shows up to like spray your lawn or to spray for bugs at your house with those like tanks on their back and the little, they did that with those same things, the same ones that are used by garden care people, except they were filled with bleach, and they would show up to a place where a patient was thought to have Ebola, and they would start by just spraying the ground everywhere they walked, spray all around the house. They would package up the patient in their hazmat suits and drive them away, and then they would often die. And so families would see these workers show up in these spacesuits, spraying stuff all over their homes, taking their loved ones away to die. They weren't super keen on calling them back again the next time. And this is a real problem because they were doing what was probably the right thing to do, but were unable to culturally explain why that was important and necessary. Governments then in these war-torn areas that were very poor were afraid of admitting that they had something that might negatively impact their economic status, and that led them to sort of quiet down the problem and not ask for help when they needed it, which led us to fail to recognize the risk and not send people early enough in order to solve the problem. But all of these things aside, we find ourselves in a situation where we have a massive outbreak, and that is when everyone needs to be concerned. But this doesn't just happen with Ebola. It happens with all sorts of emerging infections across the world every day. We're going to use Ebola as a case study to talk about how these things work. But there's Middle Eastern respiratory syndrome, there was SARS before that, there's variant influenza viruses that come out of China. Even places with the better infrastructure have problems with emerging infections. So preparing to take care of patients with Ebola is daunting. It is difficult. We faced a list far longer than would fit on this slide, and of questions as to how we were going to adapt the American medical system to be able to provide care for something that was this infectious. And it's important to remember that Ebola is much less infectious early on in the course of the disease, and as it progresses, the patient becomes more and more infectious as the viral load increases in them. And so we needed to be prepared for that patient that was near death who was just covered in virus. And we asked ourselves, where are we going to put them? Who's going to take care of them? Where are we going to get the equipment that we use to take care of them? How are we going to reprocess that equipment? What are we going to do with the waste that comes from the patient? Where are we going to put the water that they use to clean them off with? What happens about, like, if the patient's urine and stool, is that going to be a problem? And it goes on and on and on and on. You can imagine absolutely every single thing about the patient must be segregated. But hidden inside of these questions that seem like very procedural issues about, well, how are we going to solve this problem? How are we going to solve this problem? How are we going to solve this problem? Are a lot of ethical questions. And they hide in every single time we prepare for an outbreak or every single time we respond to an outbreak. Things like, who's really going to care for this patient? That's not a question of logistics. That's who should, who's supposed to. We're a training hospital. Should trainees take care of these patients? What can we do about available laboratory tests? We can't just send these specimens down to the same lab so that the same lab workers can just throw them on the same machine with everybody else's stuff. So who's going to run the labs? And what if we can't run everything we can run for every other patient? And then what if somebody needs a CT scan? I can't have a separate CT scan just for Ebola patients. And I can't really put another patient in a CT scanner after a patient's had a CT. What are we going to do if a patient needs? Is it okay to say in a Western healthcare system, sorry, you just don't get a CT? When I would order a CT, this morning I saw patients in the hospital on the infectious diseases consultation service and recommended 4 CT scans today. That'll happen before the end of the day. That would not happen for an Ebola patient. And that question brings us to, what if someone's pregnant? We know that outcomes are really poor for delivery of babies to mothers who have Ebola, but that's really poor in Africa, where there's not really a safe place to do a C-section, much less a safe place to resuscitate, no neonatal intensive care unit. We have an awesome neonatal intensive care unit here. So wouldn't we want to use that? But how would we utilize it? And how could we make it safe? Should we resuscitate the baby, or is that too much risk to the providers? We had already seen that there were providers that had gotten sick in Texas. And so a lot of these questions become very difficult. What if we have a child? Can the family come visit the baby? Is that okay? We know that the family has been with the baby, but as the baby or child gets sicker and sicker, they'll be more and more contagious. That's not the same. Can a family member actually really understand what risk they're taking on by spending time with their child when they have Ebola? And on the other hand, can we really provide the care and support that a child needs instead of their parent when they're sick with Ebola? So we really needed to make a lot of decisions here. And the first one I want to talk about is who should care for these patients. And so that's a really important one. And it brings us to, should people be able to opt out if they don't want to? What if someone says, I'm pregnant, I don't want to put my baby at risk? Is that a good reason not to take care of an Ebola patient? And what about our trainees? And how are we ever going to make this decision? Because we don't make these kinds of decisions very often about how to do these things, but we have in the past, right? So in the past, we've had other outbreaks. We've had outbreaks when HIV came on the scene in the 80s, and there were a lot of questions about, could surgeons refuse to take a patient to the operating room because they had HIV? These are questions that are still being answered in some parts of the world today. And we found that if we can mitigate the risk to the provider significantly, that they should be expected to care for that patient just like everyone else. But there are also some issues with how we would logistically get everyone up to speed with how to take care of an Ebola patient. So we answered this question in a very University of Chicago way. We talked to all of these questions, in fact. We talked to ethicists, we talked to infectious diseases specialists. I happen to be both of those. We also talked to critical care specialists. We also talked to emergency preparedness people, and we talked to the administration, and we talked to nursing specialists, and we tried to figure out the best possible way to do things because, as you all know, being alumni from this kind of institution, we want to do it the right way. And so that's what we did, in my opinion, which I suppose is a little biased, right? Anyway, so the history of the idea of the duty to care on the part of the physician is that in some instances, some doctors run away and some stay. And there are good reasons why one might do both. So imagine, duty is not actually infinite. So in other words, people don't have to take care of everything that comes their way when they're a physician, right? So there's competing duties. A physician who has 100 other cardiology patients to take care of that day may say, if I get hurt taking care of this patient with Ebola, I could endanger my other 100 patients with cardiac issues, and I'm not a specialist in Ebola anyway. And so why should I be asked to take care of that patient? It's a very good argument from a utilitarian standpoint, right? Because I might hurt more people by doing good for one. And so what about the institutional obligation? That brings us to the University of Chicago felt very strongly that we had an institutional obligation to be able to care for any patient that came through our doors, but that doesn't mean necessarily that every single physician working for us has that same obligation. This comes down to the doctrine of right place, right time, right skills, which essentially says that if you're an ophthalmologist walking through an emergency department and someone has a code blue, The person who should run the code blue is the emergency room physician, not the ophthalmologist, right? And this is because you want to have someone with the right kinds of skills in the right place at the right time. If that same ophthalmologist comes across a man who falls down on the street and there are no other physicians around, he should certainly start CPR. But in the context of an emergency department where there are highly qualified individuals, he should not. And that gave us a good solution to find that we decided the best solution for this problem was to use volunteerism amongst people that were qualified to take care of these patients. So how did other institutions do it? Well, we did a survey of all the other institutions that are listed in the US News and World Report Honor Roll, both for medical schools and for hospitals. And we asked them very early in this process about who they were going to allow to care for patients with Ebola. And you can see that the answer to this question was nowhere near consensus, because everyone's all over the map. It seems pretty clear. The red means that they are not allowed to care for Ebola patients regardless of their volunteer status. Yellow is they're allowed to care if the caregiver explicitly volunteers, so an opt-in program. And the green means they can care for patients without regard to their volunteer status, right? So everybody's expected to do it, essentially. And you can see that it's really all over the map. So there are some people that everyone says, like medical students really probably shouldn't. This is not a learning experience. It's not a good time to be learning the basics of patient care when you could die from Ebola. And so really, once you get past interns and nursing students, it's kind of all over the map. Some places said everyone should be expected to care for these patients. And some people said you should only do it if you volunteer. And some said, well, we wouldn't let them take care of patients no matter what. So the University of Chicago really felt that physicians in training is by its nature evaluative, right? So we're trying to figure out and teach them to be a better physician and evaluate how good they are. That may encourage people in a coercive way to volunteer to do things that they aren't ready to do. And so that wasn't an appropriate experience for them. We also think that inexperience with procedures increases their risk of contracting infection. And trainees, while inexperienced in independent practice, are also the most experienced in day-to-day care of patients because they provide the bulk of day-to-day medical care for everyone else in the hospital. People like me, the faculty and attending physicians, consult and help the residents know what to do and oversee them. But I don't put in any orders for patients. My residents and interns do that for me. So we needed to find a group of people who were going to be able to both provide high-level care that they were comfortable and familiar doing, but also would be able to write orders and notes. And we struggled a little bit with that, but we found them. So the CDC also recommended minimizing care providers. So we allowed fellows, we thought that fellows in advanced stages of training in critical care areas probably understood what they were getting into and were able to agree whether or not they were willing to treat, so that we allowed them to opt in if they wanted to. Otherwise, we required that it was only volunteers from the critical care groups that we felt were capable of taking care of patients. At the University of Chicago, we used largely anesthesia critical care providers. Those of you who are physicians in the room will understand that they're able to intubate patients and do other procedures that regular critical care physicians were not. We also used regular critical care physicians, but we scheduled them in such a way that we would be able to provide as many services for the patient with as competent providers as we could possibly provide. Questions? No. Which brings me to the next question of, is the standard of care different for somebody with a dangerous transmissible infection? Is it okay in a Western medical system to withhold usual treatments because of risk to the medical team? And where do we draw the line about what's acceptable and what's not? And this is a question that has not really been answered anywhere. So in real life, the way that things work from an ethical standpoint is you talk to a patient and you explain to them what risks the treatment or intervention or surgery or diagnostic test have and the potential benefit that may come from this. And the patient gets to express their preference about which of these, about whether or not they want to have that particular thing done to them, right? This is respect for autonomy. It allows the physician to provide some measure of beneficence or idea that we're providing the most good for the patient, but they ultimately get to choose. When you bring in the risk to the provider, it changes the scales entirely. Because now the same provider who's supposed to be presenting a balanced risk-benefit equation to the patient is also at risk from providing the procedure or whatever treatment. And that changes the way things are. And so we decided that there would need to include the provider preference in this. If a provider felt completely uncomfortable doing a particular procedure, we would need to find another provider who would be willing to do it, or we would need to have an ethics and medical review team that could review that decision and make a decision about what's really best for the patient outside of something a little bit more objective than just that one person. And you'll see that our way of handling that situation is a little different than the way other people did. So we asked these questions of all the other universities as well. And this is even more all over the map than the other one was, which basically says the green is we'll provide this particular intervention no matter what. The yellow is we may or may not. And the red is we'll never give it no matter what to a patient with Ebola. And I want to point out to you, like if you look, some of these things are CT scans. Almost no one's able to provide CT scans, which is actually, honestly, mostly an infection control issue because you can't clean the CT scanner adequately. Yes? Oh, I'm sorry. I'm supposed to remind about the microphone. They told me if I didn't do that for the first person, then no one would ever do it after that.
So when you talk about one physician, I don't know if hesitancy is the correct word, and then you want the question reviewed by an ethics committee. What kind of time frame are you talking about here?
So,
are you talking 4 hours? Are you talking 48 hours? What are you talking about?
No, minutes.
Minutes.
So there's like a team, there was always an on-call ethicist and infectious diseases physician who were not primarily responsible for taking care of the patient, plus one of the medical specialists. I act as the main medical specialist. So me, plus an ethicist, plus another infectious disease physician. I don't actually get to take care of the patients because I have to not get Ebola so that I can keep running the program. It is, right? The medical specialists are in a hospital incident command system, which is the way that most people respond to emergencies. The medical specialists are never actually allowed to take care of the patients. They only supervise so that they don't, because otherwise you can't be objective about what's going on. So there's an ethicist, an infectious disease physician, and a medical specialist who would be available at a moment's notice to answer any questions about what the right thing to do is, and they're always apprised of what's going on with the patient. When we care for these kinds of patients, there's like a command center set up with like closed circuit TV viewing of the area where we take care of these patients, which is closed off from the rest of the hospital, and there's a team of people there 24 hours a day watching the video, keeping track of what's going on, and communicating with the providers all the time. It's incredibly expensive. Yeah, that's all I have to say. So you can see things like MRI and CT scans can't be done because they can't be cleaned properly. But there are a lot of other things that are all over the map, like a code. What if a patient needs to be coded, like a code blue, their heart stops? Should we try to resuscitate them or not? And we'll talk more about that in one slide. And then there's other things like mechanical ventilation. There was a lot of criticism leveled at that hospital in Texas for actually even bothering to intubate the patient that died, Eric Duncan, who died, because why did you even do that? That's a risky procedure. You put people at risk by doing it. And we felt pretty strongly that this is a Western healthcare system, and we can provide, if we can do it safely, we're going to do it. If we don't think we can do it safely, we're not going to do it. And so it really comes down to safety, and that how safe it is and for the provider and the patient and how much they need it is a constantly moving target. And so you have to continually reevaluate things. But if you only think about it as a medical issue, you will fail to recognize how important it is to have a look at that constantly moving target. You can't make a blanket statement about any of this. And the most important takeaway point today is that making a blanket statement is probably the worst thing that you could do whenever you're dealing with an ethics situation. So a unilateral do not resuscitate order. This is an example. You all are familiar with this idea of a do not resuscitate order. It means that if your heart stops in a hospital, the one thing that will by default happen to you, no matter what else, there's no order is required, you will be resuscitated if you're in a hospital. It's the only thing that you actually need an order to stop in a hospital from happening. And so we don't usually do that unless someone really agrees to that. And in this case, it's controversial even in a non-Ebola patient to say, even though this person says they want, or their family say they want everything, we know they're dying. And the family is just not coming to terms with this. And it would be harder for the patient if we resuscitated them. We find ourselves in this position a lot as physicians because many people don't like to plan ahead for death, which I get, but it would be helpful to all of us and all of you if you did. Nonetheless, it's very controversial to make these blanket statements, to decide unilaterally, I know what's best for this patient, the family's wrong, we're not going to resuscitate them. And we don't usually do it. You have to have an ethics consultation. There's a lot of review that has to happen. And sometimes in patients with Ebola, these resuscitations aren't necessarily futile. There was a lot of talk in the media that resuscitating these, there's no point, they're going to die anyway, right? But that's not true. Ebola has a 50 to 80% mortality rate in Africa. We have IV fluids, which is a step up from what they have in most Ebola treatment centers in West Africa. And that's just the beginning, right? So perhaps if we did these things, the mortality rate from Ebola wouldn't be so bad. We know that patients arrest because of electrolyte abnormalities or an imbalance of electrolytes. If they have a pulmonary embolus, if they have something else going on, they contract an additional infection. All of these things can happen in Ebola patients, and we can fix them. They're easily reversible. That's not imminent death for an Ebola patient. That may mean something that we can actually fix. But we need to find a safe way to do it. So at our hospital, we have a very complicated quarantine plan. There's 2 nurses and 1 physician all the time taking care of the patient. We clearly could not have the usual team of an intern and 2 residents and some, ancillary staff show up with a cart that gets, just wheel it into the quarantine area and start doing CPR wearing their regular gowns and gloves. That's not going to work. So we needed to make sure we had a big enough team to be able to provide that kind of care, and they needed to be in their gear already and ready to go because it takes 15 minutes to put on the stuff you have to wear when you're going to take care of an Ebola patient. And there needed to be equipment stocked there specifically for the use of these patients. But we were able to provide that. If we just address the fact that ethically we don't think it's a good idea to give a blanket DNR, we think we can probably save these patients and do it safely, we just need to figure out the logistics to make it work, we can do it. So we have a lot of very proactive management. If a patient becomes very unwell, we intubate them early because it's much better to do it on an urgent basis than on an emergent basis, right? And so everyone gets early treatment of things. And that brings me to the other treatment limitations that we were discussing, which is that fear is very different from reality. And allowing the physician who's caring for the patient to be afraid of what might happen to them if they do something is not a good reason to not provide care to a patient. We saw that when we first had HIV, and we saw it with we see it with SARS, we saw it with SARS, we see it with other things. And letting people who are really cowboy and like, I'm not afraid of anything, I'll do anything, letting them go in there and do things that are crazy and get sick is also not a good idea. And so we have to find some sort of balance. So the balance is really to mitigate the risk. It's to reduce the effect of the risk to the provider to the smallest amount possible so that it doesn't have as much bearing on the outcome, right? And that's why everybody wears these spacesuits. And so we put everybody in full Tyvek suits. They wear actually disposable underwear. They shower. When they get there, they change into this disposable underwear and these disposable scrubs. And then they're allowed to enter into the quarantine area. And then they put on these over gowns like you wear in the operating room, these blue gowns and all that stuff when they're not taking care of the patient, when they're going to go into the patient's room, because the quarantine area actually has 4 rooms, one of which is entirely devoted to containing waste. They put on these spacesuits, which are basically the same thing, Tyvek. It's what you wrap around a house when you're doing construction and you don't have walls. That's what those suits are made out of. And they have 1 pair of gloves under, 1 pair of gloves over, an additional pair of Tyvek sleeves over the top of that, because this is where you get the most dirty taking care of a patient. Much easier to take those off and then remove the whole suit in order to reduce the risk of transmission. They have these Crocs that are sort of bleached every night or after every time they're worn, with disposable socks, and then these disposable boots that go over them, plus then these shoe covers, and those suits are footed as well. And they have to step onto this pad that has alcohol, and it's like saturated with alcohol, and you have to step on it, and then you have to step off of it in order to walk into or out of the room, or into or out of the unit. And that makes it so that we can do a lot of things to patients. But our healthcare providers weren't really very attuned or used to doing things in these outfits. And so how do we make it so that it's safe for the patient to have these things done by people that are not used to this? And the answer to that question is training, training, training. And so we had one of the most robust and best training programs probably in the country. We got a lot of kudos from both OSHA and the CDC for running a great training program. We used our colleagues at Ricketts out at Argonne, who have a level 3 biohazard lab where they deal with plague and anthrax every day. They wear these suits all the time, and we had them come over and we help them when they do things like spill anthrax, which they do. And that's what my phone rings, that's what they say. So we asked them to come over and help us, and they walked us through their usual, they taught us, they did all of our training for us, they taught everybody how to do this. Everyone practiced on our simulation models that we use in the hospital for teaching our residents and fellows how to do central lines and how to intubate patients and how to do procedures. We got all of them out, put them in these quarantine beds, put everybody in these outfits, and had them practice until they were really competent and confident in doing it. We also, there's a lot of other words on this slide, but I don't think they're as important as what we've already talked about, so I'm going to go past them. So can we tell the difference between the fear and the safety, and who's going to hold people accountable for this? So the way that the University of Chicago has approached this is different than how other people have approached this. I want to read to you from the American College of Obstetrics and Gynecology Practice Advisory, because it's important to know that our aggressive stance on taking care of patients and doing everything that we would usually do to take care of patients and making it as safe as possible and investing whatever we needed to invest in order to be able to do that is a little different. So they said it may be prudent to avoid the usual obstetric interventions such as fetal monitoring, cesarean delivery, induction, or surgical repair of lacerations in this select group of extremely ill women. Those are women with confirmed Ebola. For all women with EVD, that's Ebola virus disease, there will be a window in which EVD is suspected, but has not been confirmed with laboratory testing. These women should be treated in a similar fashion to that described above, recognizing that a portion may prove negative. The proportion of people who tested negative for Ebola in this country who were suspected of having Ebola was 99%. So imagine if you had a 99% chance of not having Ebola, and we said, sorry, we're going to let you and your baby die because we are afraid. We don't think that's appropriate here. And we admonished the ACOG in a different publication, but that's neither here nor there. So it's important to know that this fear is very real. You all saw it on CNN. You all saw it on any news station that you watched, because this is really driving us when we're handling issues with really serious infections. But we have to take a step back and figure out what we're really afraid of and how we can make that go away. It's the same thing as when I tell my 6-year-old son, he says there's a monster in the closet, and I say, let's open up the closet and see. It's the same exact thing we have to do with stuff like this. And so, the ACOG has stepped back from this and we will provide any care that we think is medically possible to provide safely for mom and baby. In other words, for mom and baby safety. If mom is having a lot of extra bleeding because she's unable to clot her blood, which sometimes happens in Ebola virus, it happens often in Ebola virus disease, then it may not be the best thing to try and save the baby. Maybe we just save mom. But if mom definitely doesn't have Ebola, or we're pretty sure she doesn't have Ebola, and we could save both, we'd do a cesarean section. We'd do it in the room, in the quarantine area with these fancy schmancy portable procedure lights and all this awesome equipment that we have. And it's super good. Those of you who do medicine will understand how complicated that is. But anyway. So we know that there are very poor outcomes for babies born in Africa of moms that have Ebola, but we know that we can do better than that. And so we should. So we do active ongoing assessment with fetal and maternal monitoring, avoiding but not prohibiting surgical management, which luckily we have not had to do, because the majority of people coming back, you all know how it works, right? People come back from that part of the world, they get caught at the airport by the health department, and they're followed very closely. Anything at all happens to them, they get a fever, and they end up in this unit of ours, and they're cared for there where they can be monitored really closely until we're certain that they don't have Ebola. Most of the patients that we take care of have influenza, but we have to care for them as though they have Ebola. So what happens you all have heard of HIPAA, right? The Health Insurance Portability and Privacy Act. So what happens to HIPAA when someone has a contagious illness? How much information can or should be released to the media? I've referred to Thomas Eric Duncan's name many, many times so far. He has zero privacy, none. And so is that acceptable? Is that okay? What do we do when we have patients in our unit, and how do we decide what we're going to do? Well, there are some rules that we have to follow, government rules, and they're not quite what they are for other things, right? So infections are a little different. Healthcare entities can legally release private health information to public health authorities without patient authorization for the purposes of preventing or controlling disease, injury, or disability. That's a very broad statement. So your health information is less private than you think it is, first of all. Second of all, this is also true, which makes it even less private. But public health agencies, we can tell law enforcement, we can talk about product safety recalls, we can let anyone know, there's mandatory reporting for illnesses like syphilis and HIV, and they will contact all of your sexual partners and let them know anonymously that they have been that they were identified as a potential contact for one of these infections. And so we know that this is going to need to happen for Ebola too, right? But the question is how much? So there's been some, back in 2001, there was an idea about having this Model State Public Health Privacy Act, which is basically a law that sort of sets some more guidelines for these things. It hasn't been passed by all the states yet, but we sort of use it as a guide for us to help us decide what we need to do. We know that the public should know. I mean, when we have to open up our quarantine unit to take care of a patient that potentially has Ebola, people are, in my opinion, they deserve to know that that's happened. It's a concern for public safety, but they don't need to know all the details of exactly who is sick and what they're sick with. Only the people that were contacts of that patient need to know about it. And we do. The health department in Chicago is actually very good at doing some really aggressive contact tracing, and we work very closely with them. So then I want to switch gears and talk a little less about what we do at the University of Chicago to another big ethical issue with Ebola and with other infectious diseases that are emerging, and that is to talk about whether or not it's ethical to use drugs that were never tested in humans to treat patients with Ebola, to prevent Ebola, and how should we decide who gets them. You all know that the patients that did have Ebola got various, TKM, whatever the number is, I can't remember, and brincidofovir and any number of different antiviral drugs that were never tested in humans before when they had Ebola, and there were a lot of questions about whether or not that was right to do. So remember, this is the worst outbreak of Ebola in history with many complicating factors in terms of controllability. There were no prior commercial incentives to develop drugs or vaccines. People were just working on these out of their little labs. There was no money spent to make them into huge, large-scale trials, nor was there any disease to try them in. Rare outbreaks meant there were limited opportunities, and many of these interventions were ready to go for testing, but there was no outbreak until we had this massive outbreak. And then the tables kind of turn when you have an outbreak situation, because it becomes a little bit more difficult to make it about, a fair, honest assessment of whether or not this drug is really working. And so the basic principles that were set forth by the World Health Organization advisory panel on the ethical considerations for the use of unregistered interventions for Ebola said that experimental drug use should not divert attention or resources from public health measures or usual supportive care. In other words, we shouldn't provide people with this to the detriment of giving them rehydration and all of the other things that they need. We shouldn't waste public health resources in Western Africa on things that we don't know are effective instead of giving them things that we know are effective. We must collect adequate data on those who get experimental treatment so something of value is learned. This is an important point. That's basically saying, the idea of saying you can't get this drug unless you let us study you is not very, we shy away from that in an ethics standpoint most of the time, because it seems like a life or death drug, you should be able to get it. But in this case, there's so few patients, it really is acceptable, and it's necessary in order to know what to produce and what to give to patients in the future, because we knew nothing about it. So you must be able to collect data on the patient, and that was sometimes impossible in some parts of West Africa. It's also, you have to use the best risk-benefit analysis, considering what you should know. In other words, it should work and be safe in our closest relatives, which are primates. And you have to decide what criteria will be used for access before you start distributing it. You have to have transparency of clinical uncertainty, which you all know we do regularly. And you have to think about feasibility. Something that needs to be stored in a refrigerator should not be distributed in Guinea. They don't even have IV fluids. I want to point that out. These patients don't get IVs because it's not safe to put the IV in. They don't have enough of them, and they don't have any IV fluids to give them anyway, which is the only blood test they have is for Ebola. And then they are given oral rehydration solution. We can do better than that here, and we do. So there are ideas about how to allocate these drugs, and these are basic ethical principles about distributive justice, which is fairness between countries and amongst populations within countries, reciprocity and social usefulness, so prioritizing healthcare workers because they can then go back and take care of more patients, and they didn't need to be exposed, although probably no one needed to be exposed. The likelihood of positive impact on individual and public health outcomes, that's basically triage. This is the idea of, we help the sickest first. Actually, we don't help the sickest first in triage. Triage, technically, if you didn't know this, you'd think that the sickest, in emergency rooms in the United States, the sickest get help first. But the idea of triage actually comes from the battlefield in the First World War, and it was the walking wounded that got the first treatment. Those that were dying were left to die, given morphine and a leave alone, because they can't be saved without using too many resources on one individual. The walking wounded, those that could possibly be actually helped, were the ones that got first crack at treatment. And the ones that were well enough to not need immediate attention, just keep fighting. And so that's very different from how we do things in medical care. But when it comes to giving these drugs, it makes sense when you only have 20 doses of some of the drugs. They should be given to people who might survive so that we can make sure that they're at least safe and not confuse the picture with them dying from something else. Best match therapies are based on what is currently known. Children and pregnant women probably need special protections. We involve families and communities in decisions, and we use usual informed consent and proxy rules. In other words, if someone can't make decisions for themselves, we go to their nearest relative or the person they've already designated. And that is pretty much the main things I wanted to discuss about Ebola. And this is a lovely sign that we use to remind our healthcare providers that they will be okay as long as they just ask patients if they've traveled and if they have a fever. Okay, that's all I have to say, but I think there are questions now, right? Any questions? Wait, microphone. I'm supposed to train you about the microphone. That's what they told me.
Well, the question I have is this. I mean, the model that you showed is a model that applies to single cases. I don't think that during this epidemic there was more than one, maybe two patients in the same center, and probably all the patients that got treated here were during the whole outbreak was less than they would get one day in Monrovia. So I don't see how these models can be applied if you had 150 patients, 50 patients in a single city.
Yeah, they don't. So the idea is that if we do everything right for one or two patients, we won't ever have 150 patients. So this is a model that only works in a Western-style country where we already have great healthcare and we can identify these people early and keep them from transmitting the infection. Once the infection's out of control, there's a whole different way of thinking about how to manage outbreaks. And what they did in Western Africa without IV fluids and without testing is the right thing to do. They did what they could with the resources that they had. But we don't have to do that if we do it right from the beginning. So you're right. We wouldn't have been able, but that's why we worked with it. So Chicago has a Chicago Ebola Resource Network, which is us and Northwestern, Children's, and Rush. And we work together to take care of patients, so we switch off so that no staff is ever exhausted or unable to take care of patients. And that way we work together. We pool resources if we have stuff that they need that they don't have in terms of like extra hoods for their pappers or whatever, and that way we can have a citywide response that can help keep us from ever getting to the point where we have a huge surge of patients. But as a city, we can take care of 10 or more at a time, which should be enough to keep us from having a major problem. Okay. Hi.
Yeah, in a way, he already asked the question that I was going to ask, but I'll phrase it differently. And that is, you started out by saying you wanted to use the Ebola situation as sort of a model for understanding what to do. And so I'd like to sort of ask the question, what does one do, what have we learned about, or what could we learn about, how do you deal with a situation of highly contagious, high death rate in a place like Central Africa versus what do you do here? And I think you addressed partly the here, although I'd only like to comment that what would happen here if we had a situation of a highly contagious, high mortality rate outbreak of something? Because you're really only dealing only with something where single patient, quickly identified, and not very transmittable, probably not a high death rate.
So what we do, we have a plan for a high surge mortality type situation, which is basically we close down all of Mitchell Hospital and move all the patients out of Mitchell. So we have multiple hospitals over there. I don't know if any of you have been there, but there's multiple different buildings. One of them all the patients get moved out of that building. It becomes the Ebola Center. In that case, the volunteerism issue is going to become a lot trickier. And so we have levels of staff that would be expected to take care of these patients, and from other areas we would accept volunteers, but that volunteerism kind of has to go out the window a little bit, and you'd have to opt out of taking care of the patient. You would be expected to do it, but you could opt out, especially. And then the next level is if you absolutely can't meet the needs of caring for the patient with that, then you can ask for, you can start setting limits as to who's allowed to opt out. We don't want to get to that point if we don't need to, but we have a separate hospital that we can put all these patients into. The city prefers a model where everyone goes to one hospital and the providers from most of the hospitals come to that location to care for the patients. Amongst those have been trained, and then you step up your training for everybody else as quickly as you can. Contain and manage. But we're still a Western healthcare system. We have plenty of resources. We should not ever have a situation where we have people that can't get IV fluids, right? We may not be able to provide everybody with with a surgical procedure like an intercurrent appendectomy, right? That needs to be done. They would need to get IV antibiotics instead. So there are ways we can manipulate these things in order to make it. But the city's plan is to put them all in one place and to have the care providers that are trained to care for them come to that one location. And then there's a separate holding area for people that are being tested but haven't ruled in or out, because they are much less infectious than the patients that are known positives, right? And so you can put the known positives into one building. You put the ones that are much less infectious, test them quickly, and all of our testing turned around very quickly. The health department's quite good at that. And then when they're positive, you move them into the high containment area, and the negatives get sent out. So there's a plan. It's just not as likely to happen as long as we do everything right the first time. The problem they had in Texas is that they used that approach of how would they handle 100 patients with Ebola? Well, we would put our people in as much PPE as we could. We would try and keep them separated from everybody else. We would train people up right at the last minute, right before they got there. That didn't work. That's why we had additional cases from that. If they would have followed a high containment search and destroy type methodology, we wouldn't have seen those additional cases. So the idea is that we don't want to ever get there, but we have a great plan for it.
Is there ever a situation where you would essentially take a population in an area and totally isolate them?
Yes.
Like in
Smallpox is the answer.
Okay. In this country?
Yes. Yeah, I'm sorry to say these things because they're a little bit disturbing sometimes for some people, but if there's a smallpox outbreak in one of our communities, the borders of that community will be closed. No one's going in or out. The health department would provide us with food or whatever we needed, but no, there's clear plans for how to close a community.
Okay.
Sorry,
no,
everyone who didn't know that.
You see, I actually would subscribe to that.
Yeah, it's needed.
But I think that it goes back to your question of ethical issues. And you see, I think that what gets mixed up here, which you said, is the whole ethics of who do you provide care for, how do you provide it, do you essentially write off potentially a part of a population saying, we have to let you die.
I don't think we ever want to get to that point. So the ethical question is, when do we do that, right? So the ethical question is, when is there enough that you close the borders of a community and restrict people's freedom in order to protect others? When is it so dire that the benefit of letting some of these people die without care is of more benefit? And do you use utilitarianism to decide that? Do you use some sort of teleological reasoning? Do we use consequentialism? There's all these different ways of thinking about things that would help us come to those answers. The real thing is that you need to decide. I need to think about when is the right time to pull this trigger beforehand. Yeah, and that's what I think some of our colleagues at some other hospitals don't do as well as we do here, because the McLean Center is actually really pretty amazing ethics place in the country for clinical medical ethics, and allows us to ask some of these questions ahead of time and think about them with really qualified ethicists ahead of time and in the early stages, instead of letting things get out of control and going, crap, what are we going to do now? And we don't ever want it, a lot of times, we don't want to have to make that decision, when am I going to close this community? And so the answer is, then you look for, how do I avoid having to ever make that decision? And the answer in the case of smallpox is vaccination. There is a way to avoid that, as well as a way to do it.
Who from the university interfaces with city services and waste management, and did you have issues around that? All you. Okay.
No, not just me. There's a whole team of us. But yeah, I mean, I have the health department communicable diseases physicians on speed dial on my phone, because we run this rickets lab out there too. There's no shortage of nasty infections all over the place. And so, no, we work really closely with them. So when you have an outbreak, like a massive problem in a hospital, right? Something where you're going to, we have this system called the Hospital Incident Command System, which I've already mentioned. It allows for, there's medical specialists, there's liaison officers. The liaison officers have regular meetings with the city and the health department. Then there are people that do different things. There's incident commanders. There's all these different roles in order to standardize how we communicate with these people. But it does take a ton of work. I mean, we had to work with our Stericycle, the people that remove our waste. We had to negotiate with them how we were going to do it. We had to work with our own, we don't allow our waste management, our usual environmental services, housekeeping workers do not help take care of Ebola patients. Our physicians and nurses actually take care of the waste, because it's a much more difficult process than you think. It takes 20 minutes to remove the garbage.
We have time for one more question.
Oh, he's hard. Okay.
Well, it seems like the best way to make sure this stuff never happens is just to prevent it before any of this ever happens. So what are we exactly doing to educate all the other countries that could have these problems and don't really trust us that much? What are our measures to help them before it ever gets bad?
So education is a key piece. But what we do know, the most important thing that I could tell you about preventing infections in hospitals here, preventing outbreaks anywhere, preventing anything, is that education alone is never going to work. And so what they need are money and resources. And then they need cultural expectations that this is going to work out, right? So we have a cultural expectation that Ebola is not going to outbreak in our community. And it would be, when we had 2 cases, one Thomas Eric Duncan, 2 nurses, people were out of control because we don't allow it to happen. So the answer to your question is that the socioeconomic status of the people living in that part of the world needs to increase. They need to then invest in healthcare infrastructure and actual care. They need to invest in the actual infrastructure of the people's living environments, pay attention to clean water and clean food. Then they need to help people to come along and understand that they should take people to the hospital and trust the hospital when their loved ones are dying. And then once those loved ones die, they have to dispose of them in a way that's safe, and they have to sort of rearrange all of their cultural principles for years. It's really hard. Yeah, and that's just 5 steps out of 1,000. And so the truth is that we'll do what we can to try and fix this. Those countries have learned an important lesson, but it's not just about wash your hands. I mean, I do research in healthcare provider behavior, habitual behavior, and hand hygiene. And that's so much easier than this stuff. And it's also really, really hard if anybody wants to talk about that.
Let's give Dr. Landon a hand. Dr. Landon will be available after the talk for any further questions you might have. For more than 125 years, the University of Chicago faculty, students, and alumni have defined disciplines and shaped the world through a singular focus on a kind of rigorous, intense inquiry that you heard about today. Friends like you feel every aspect of education and discovery at the University of Chicago. You can stand with more than 40,000 alumni by making a gift to the University of Chicago's current campaign, Inquiry and Impact. The campaign is the university's most ambitious and comprehensive to date. We aim to raise $5.1 billion and engage 125,000 alums, that's about 3/4 of all the alums, to support faculty and students across the university and to foster a stronger, more connected community of alumni around the globe. Your engagement in lifelong learning through events like this UnCommon Core help foster an environment that spurs more insights and innovations, solutions, and cures. Discover more about faculty research and giving opportunities at campaign.uchicago.edu, and we hope you enjoy the Alumni Weekend, and thank you for coming.